Alrighty. So while we wait for people trickling in and also Matt joining us, maybe Melody, a question to you while we wait. What is the book that you've recommended most to other people, and why is that?
Oh yeah. It's funny because I was just saying I think it's really hard to choose books. I have a hard time. I tend to go for all the like organizational psychology and self-help, but one that was really refreshing was Atomic Habits by James Clear. So it's all about tiny atomic size changes and how designing your system is critical. And it uses data and graphs, and so it kind of appeals to everyone in terms of like breaking down a change to like bite-sized steps. But it was really refreshing and really good. Trying to think what else from that book, but I've been recommending that for months now. Yeah, it's a good one. Are you familiar with it?
Yeah, I am sorry. I'm getting or trying to get Matthew access to the Zoom.
Oh yeah.
Apparently, he's an attendee. He forgot that he needs to join in as a panel. So maybe while I fix that, Thomas, what's your favorite book that you've read lately?
So I'll say what book I've recommended most to other people. It's Persuasion by Robert Cialdini. I think it's a book that really opened my eyes to the hidden forces that people use in marketing and building building products, and in just in real life when you're working together and you need to collaborate to get stuff done. Persuasion is a very important aspect, and I think it should be a book that everybody has to read in like when they're 16, because it really opened my eyes. And now I've never looked at an ad in the same way since reading that book. And so I've recommended it to a lot of people. And then the book I've been reading lately, and I've been reading it for way too long, is Reamdy by Neil Stevenson. It's the author of Snow Crash. It's an amazing author. But this is like 1,100 page book, so it's been pretty chunky. And given I have very filled agenda, I can only read a couple of pages per day. So I've been plowing through it for months basically, but I'm almost there.
Alrighty, Matt is always or soon here. Send him the right link this time. So maybe while we wait for Matt Melody, can you already briefly introduce yourself to the audience and what you do at Sutter and why you are here today?
Yeah, sounds good. So I am a manager for nursing and population health. And so I oversee a team of RNs, a case manager, social worker, so day to day working on the role of team-based care and designing that with primary care clinics. And then I also have a strategic role in preparing our division for population health. So it is not a small undertaking. It requires, the language of population health, a lot of change management, a lot of building of fundamental building blocks to get them ready, the infrastructure to support it. And yeah, so that's a little bit about what I do currently.
And there we have the last guest as well. He's here. Hey, Matthew.
Yay. Good
Well,
morning.
Rick, you're a wise man to build in that buffer time, mostly for.
No worries, we're just doing intro. So can you maybe, sorry for jumping straight in, but can you maybe briefly introduce yourself to the audience as well?
Yep, Matt Sakumoto, virtual primary care doc based out of San Francisco. And then my admin role is kind of an informatics physician leader for the San Francisco area.
Right. Happy to have both of you here. It's definitely an honor based on all the research and the stuff that you both wrote. I think you have a lot of good things and interesting things to say about CareOps. Before jumping into all things CareOps, maybe Thomas, can you also introduce yourself to the audience?
Sure. Thomas, co-founder, CEO of AOL. It's AOL's mission to make care flows work harder than care teams. I'm originally from Belgium, but recently relocated to LA, where it's currently June gloom. for those of you who don't know, it is gray in the morning and sunny in the afternoon. And I'm also co-author at CareOps together with Rick.
Yeah, and I'm Rick. I'm a trained oncology nurse, and I lead clinical strategy at AWell. All right, let's dive into it. Maybe the first question that I have for Melody or Dr. Matthew or Matt, what is the North Star metric at Sutter Health within the primary care population health segment, and how have you defined that?
Melody, you can go first, and I at least.
Yeah, we love metrics. Okay, so this is really fun. We have a new president and CEO, and I worked at Sutter Health a couple of times over the years, and we've had 37 scorecards, dashboards, metrics across the system, and we've finally gotten to a place where we have one scorecard. So that is a huge feat. Within 1 year, they, did a lot of work to solidify that. But my North Star continues to be, and will probably always be, the quadruple aim or quintuple aim, because it was started by clinicians, who wanted to improve the system. So that always resonates. And then recently, we took the quadruple aim and just aligned our system scorecard with that, so that all the metrics we're accountable for line up perfectly with the quadruple aim. So it's something that folks can relate to, no matter who they are in the system: patient experience, population health, cost of care, and care team well-being. And so that's my North Star.
Yeah, and I agree with Melody completely. I think when you focus on a single metric, that kind of, you have to have a balanced scorecard going through. So I think keeping, holding those, at least those 4 things, kind of maybe 5 things, the 5th point of that star being health equity, together in your head all at one time, I think is important. So I agree with that part completely. And yeah, I think when you get a little too myopic on a single metric, then things tend to, you lose sight of kind of holistic care.
So although I completely agree in theory, in practice, you will have to make decisions that will impact one metric more than another. Can you walk us through a concrete example of such a situation where you probably have already had that, and how you made decisions around that?
Yeah. I mean, I think, oh, go ahead, Melody.
No, that's interesting. So like an example recently, as we're rolling out this change in primary care, we've got our scorecard, we've got our quadruple aim, and there's one metric on there that we don't have defined. There's a couple that aren't defined yet, meaning we're still working on getting the data and to set the target as a system. But my job what I'm doing now is preparing the teams, doing a baseline assessment to see what they want to work on, where their strengths are, where their challenges are. And so it's been really interesting that the one that's coming to the top is focus on social drivers of health, and that's not a target that the system has clearly defined. So to answer your question, I think the right strategy is to go where the enthusiasm is, and to find those champions, and to try to really hone in on that one. So that's kind of what we're doing right now. So we're going to have to learn how it all plays out, but that's an example.
Yeah, and to play off of what Melody was saying, I think the interesting role that we play is, like, we're not the big bosses. Like, we kind of exist at a regional level, right? So there's a lot of things where, like, Melody has the time, energy, and just knows the people to be able to go to every single clinic. I'm in the clinic, like I'm a practicing physician still. So that the Gemba kind of like being at the front line really makes a big difference. Again, to Melody's point, like, you kind of align with what the people doing the work daily are doing. But then to put a finer point on that, the idea of kind of putting CareOps together, it's a combination of the thing that preceded the SDOH focus was just standard work, rooming. Like, how do we get the patient most efficiently kind of checked in at the front desk, roomed, and then the clinician sees them, and then the patient is able to go on their way from the clinic. Just that infrastructural work of having standard work for rooming then allows us to say, like, okay, how does SDOH screening work into rooming? How does closing care gaps work into rooming? So there's some just like basic infrastructural things that you put into place that then you can start to layer on, okay, which part of that quadruple aim or quintuple aim do we want to focus on this month or this quarter? So that's kind of putting both together. Like, so it's like, how do we try to do it all? It's by being very good infrastructurally, and then having focuses that rotate kind of throughout the month or throughout the quarter.
So
And-
you
And
already
we're going to be
alluded to
ahead
it.
of the
Oh, sorry.
Oh, sorry. I just realized I was going to say we're going to be ahead of the game when the system, like they said we want to do this, but they didn't define it yet. So I just got excited thinking about how we'll be ahead of the game.
Yeah, I think my question was in the same direction. So you already alluded to it, Matt, that you have several levels, or regional and then the group level. Is there any friction regarding setting these metrics and then executing against them? Can you give an example of, or is it just running fluid, end-to-end, top-down, bottom-up?
It runs seamlessly all the time. Everyone is in complete alignment. I'll speak to this briefly. So the structure of Sutter, the way I describe it to kind of new hires, is Sutter is an onion. So you have different layers of Sutter. So Melody and I represent and work in the San Francisco area. There's kind of areas in Santa Rosa north of us, East Bay in the Oakland area, and then down on the peninsula, kind of in the Palo Alto area. So each one has its own separate flavor, grouping of clinicians, different patient populations. So that's kind of one of those things where how do you balance customization and standardization across some of these things? So some of the metrics, again, play to the strengths of other regions. Some of them play better to the strengths of our region. So I think that's the other reason why I keep going back to that balance scorecard thing. Is like, hey, would I love to get 100% in everything because I'm type A? Yes. But it's recognizing like these are the areas that like we're going to make the biggest impact, and it'll have the biggest impact on our patients. And then some of these other metrics, it's like would be good to have, but like our patient population wouldn't quite benefit from that. We're already doing pretty well on that. So yeah, for me, I don't know. I personally kind of pick and choose and say like these are the ones that these are the metrics that we're going to focus on because we can have it'll have the greatest impact for our patient population locally.
And so on the focus side, so Melody, you mentioned that you had 37 scorecards before, and now you have one. I was at the hospital a few weeks back, and also I think they have about 50 different scorecards. So what advice would you give to an organization? It's also a very large health system that has this very big dashboard with all of these scorecards and is trying to like create one scorecard for the entire organization. Any mistakes that you have made while doing that progress that you say like make sure that you don't make the same mistakes as we did?
Yeah, that's a really good question. And someday when I'm in charge, just kidding. I think SMART goals are always smart, right? Like make it achievable. It's crazy when you see a metric that's like so high and it's like, well, do we even know what our baseline is and what it would take to get there? So sometimes I do wonder, how did we choose that goal? But so I think that is really important. And that's also feedback I'm hearing as I'm presenting metrics to physicians that the system gave us, and, having to try to tell the story of like, what does this mean? And why did we choose this target? So that's, sometimes you would fill in the gaps or you don't have the answers and you just have to kind of admit that. And I ask, what do you think it should be? And then I learn more about what's actually happening on the ground. And then I guess I would also say, look at the market. It's really encouraging. I've worked at large payers as well to see them aligning with other payers. And, so I think that is really smart from a business perspective. Like, we've been working on quality and safety. That's the right thing to focus on. And let's align our care gap measures, with the ones that most of our payers are expecting of us, for example.
The other piece I'll say that or reiterate with what Melody was saying was that bringing the why. And I've actually a lot of times I'll say, okay, we have to do this. This is the reason. I've learned that just verbalizing like literally the why behind this is, and like bold headlining it. And this is kind of just trying to get for me, it's convincing the clinicians to kind of get on board with various new workflows or focusing on new metrics. Because a lot of times it's like it doesn't affect their day-to-day. It actually does affect kind of what happens at the end of the year, or what's happening maybe even 5 years from now. But saying like, hey, we're trying to build the groundwork now. The SDOH is a good example. Like are we required to do this? No. Are we going to be? Almost definitely. So like let's learn how to do it now. So like this is the why, and it's obviously good for patients. But headlining this is the why for this. I feel like has made a difference, and it reminds me to like articulate again the why behind it, because a lot of times just because they say we have to do it is never a good reason, or never gets people on board for that reason.
We have so when we implement new workflows at customers, we always just like went with the flow. But what we're doing right now is create like one pagers of like explaining the why now, and then like the headline, and then we just like can share that with all clinicians involved. Then we don't need to repeat the story all over again, and we also can control the narrative better because they all see the same one pager, they read it, and then they can repeat and explain to other people that were not involved in the process. So I deeply resonate with the why, and something that we realized probably 2 years too late. And as you know, so an organization like Sutter, you obviously have many care flows or care programs or clinical programs, whatever you want to call them, already in place. So how do you think about deploying a new care flow, for example, the SDOH one, versus making existing care flows more efficient or driving more or better outcomes?
I could take first crack at this. So this kind of, again, goes back to the kind of regional middle manager role that both Melody and I hold. I will often say, like, is the system planning on doing this, right? Because if we're going to design something custom that works really well for our region, but then there's going to be something from the top down that's going to change it, it's like I'm okay holding off. Versus like, well, they're never going to get to this, and like this seems like something that we need to figure out for ourselves, either because A, it's a highly time sensitive thing to do, or B, it's like, okay, we're like the only group, for example, that does a lot of transplant in the region compared to other regions. So like a transplant specific workflow is really only going to be in San Francisco. So yeah, let's start tackling that now because the system's not going to share.
Yeah, this is a really interesting question because we practice lean management and we are always learning that methodology, and we have new staff, so they have to learn that methodology. So the whole process of lean standard work is constantly, well, first documenting our core processes and then constantly revisiting them, constantly improving. We want to be better tomorrow than we were today. So I think that's key to having a culture that is continuously improving. And the other piece is like, we need to measure. If you don't have a target, you can't improve what you can't measure. So I think that's key to figuring out if something's actually broken, because we can change things just for the sake of it or because someone has a different way of doing things. Variation is okay as long as it's safe and efficient. So I think like metrics are really helpful when it comes to deciding what actually needs improving.
I'll double click on the standard work piece too. To be honest, this is a lesson that I personally learned as we went through this, building out new programs, is the go slow to go fast. Like take the time, and it takes like probably 25 to 50% longer to like have to write things down as you go along. But as I'll be honest, as staff turns over, as programs change, when you have that written record, that helps you go faster in the long run. So for me, I was like, oh, well, this takes so long to write down. But I think documentation, matters. It makes a big difference and really does help set the stage for going faster down the line.
So you're obviously preaching to the choir here with CareOps being heavily leaning on everything that is lean management, etc. Now, I can imagine that a health system like Sutter isn't born with that culture. So how has the transition to that culture been over the years? And what practical tips would you like to give to people in the audience who might already be converts, but that don't yet have the full cultural buy-in that it seems that Sutter already has?
Yeah, I can take this because I actually recently went to, well, first of all, I love that CareOps is into lean. I think it's so refreshing because oftentimes I've been practicing it for about a decade, and I've worked in startups also and learned their methodologies. And sometimes I think, is this still relevant? Like, is this just, phasing out? But it doesn't. It still works and it still resonates. And recently I met Dr. Mitnick, who was a chief medical officer and the best teacher of lean. I've had him come and talk to my RNs so that they're not just hearing it from me. And he is a proselytizer, he called himself. So he told the story about where it all started at Sutter Gould many years ago with just a handful of clinicians. And it was really cool to hear that like humble beginning story, and really affirming as well that it takes time. Like I can get really discouraged when you're working with staff and trying to learn this language together. And also, I have to constantly revisit the tools, but it can take years. And so that sometimes doesn't feel like we have that long. But that would be some practical tips, is just like patience and stay the course and keep the faith. Because and then another practical tip that Dr. Mitnick shared is that like the reason why it failed had something to do with not embedding that deep learning cycle. So I've also seen over the years, I've been part of like improvement projects at the system level. And when we had the IHI, the Institute for Healthcare Improvement, doing these really cool projects. And it's fascinating to see how the same problems we were working on years ago still exist, but they have evolved a little bit. But that it's really a shame when those things don't spread, when those learnings don't spread, or those projects, pop up in multiple places. But at the same time, I'm still a believer, and I think it still works because it's all about empowering the frontline staff. So I hope that helps.
Yeah, absolutely. To follow on this, the spreading of the learning, it's a related question. So how do you balance the need for standardizing, making things scalable across the system, versus still leaving autonomy, the importance of personalization? Because I can imagine that if you force standardization too much, you will leave people, by the side of the road because they're not bought into what they think the standard should be. How do you think about that?
Well, we face that.
Specifically around, and specifically the lens of implementing a care program or a care flow, because you can have this about multiple topics, but specifically if you want to implement
yeah, we're totally dealing with that right now. So one example is transitional care management. So we implemented workflows where RNs are outreaching patients. They are doing an assessment, getting them in with their PCP. It can break down in so many ways. So, for example, medical assistants can do that outreach, but it is a best practice for RNs to do it because it's a more comprehensive assessment. I know Dr. Sakumoto and his team, like he's got LVNs, he said LVNs doing it, MA's doing it. They do follow-ups on ER patients, not just hospital. So I love like that variety because we have a lot to learn. Maybe our way is not the best way. And it's important to keep up to speed on the evidence. So for the longest time, I think 20 years now, it's been like 7 to 14 days to bring patients in. But I've heard that there's evidence that suggests wait longer. So it's always important to keep tabs on evidence-based research and translate it into practice. But also, I love the fact that others want to do it differently. And so we'll have a standard, like we'll agree on like, we all agree patients should have follow-up. We all agree they should have an outreach call, but let's see what we can learn if we're doing it a little bit differently here. Or at another clinic, they have resident physicians, so they have to do it differently. They don't have that same PCP to patient relationship. So that's one example. I'm sure you have others.
Yeah, I'm trying to pulling on that thread. I think I use the 80-20 rule in so many parts of my life, both personal and professional. But it's kind of like we can standardize 80% of the things, right? Like let's agree on what the metric is for everyone, like time and percent of patients that are coming in, maybe kind of what that initial scripting is. What is the baseline information you have to get from the patient? Could be the nurse getting that information, medication reconciliation, referrals that need to be put in, orders that need to be followed up on. Could be an MA asking, could be a LVN asking. So the information that needs to be gathered, that should be standardized, and we have like forms essentially to fill out. But who's doing that, kind of how that flows, how that gets escalated, that'll kind of change across different sites or sometimes different patient populations. So that's kind of where we standardize it, but then you can kind of tweak it for your clinic, your patient population, those kind of things. I'm trying to think another example of standardization, customization. So we have, I think it's actually one of the most innovative things is our MIST team, multidisciplinary in-basket support team. So anyway, in-basket is the biggest like bane of particularly primary care's existence, just because of the volume of things that are coming through. So we have an entire team of medical assistants, pharmacists, and even APPs or APCs that are there to kind of be that first line of defense. So that sounds like amazing. Like you have a whole team dedicated to like handling the patient messages, but it leads to weekly debates because sometimes they're like, oh no, I want to see the patient first before you refill the med. Other people are like, no, for these kind of things, just refill it. You don't even have to ask the clinician. So getting everybody to agree on, again, this wonderful shared resource, but like, how do you standardize that and get agreement on it is constantly checking in with people. And you're not gonna make everybody happy.
So to your point about the 80%, what we often say is if you want to standardize something, there's the first 80% and then there's the second 80%.
Yeah.
So now, you mentioned earlier, Melody, that variation is okay. Can you define variation? Like, is process variation okay, or are you also looking at how the metrics and the outcomes vary across the different places where something got implemented, and how are you defining variation?
It's a really good question. So you said metrics versus process variation?
Yeah. So outcome/metrics versus process variation. Yeah.
Yeah. I was just thinking the other day how I think outcome measures are really not great. So we have to have them sometimes, but we should really be spending so much more time in process measures because there's so many processes in getting a patient from step A to Z or even A to B. So I'm really more interested in the process measures. But that being said, I struggle with having like data analytics and tools and ways of measuring. So for example, we're using the time studies. Like with standard work, you literally have to observe someone do something 30 times. And it's really awkward and uncomfortable when, as your manager, you're like sitting there watching them do the process. But really hope that they understand that this is going to pay off. This is going to be a good thing. I'm not, critiquing you. This is really so. I was really proud when the team actually came up with their time study, and we found out it took like 45 minutes to an hour to make that transitional care management call for adult patients. So that's huge because then we know, like, okay, how much capacity do we have to do these calls? And so that's work that that data hasn't existed for years. No one had any idea what a nurse does or how long this call takes. So I think like it's okay even if it's on paper with tally marks, and it's not perfect, but so I think both are important. Yeah, hopefully that answered your question. But I think some outcome measures we have to have because we need to understand, like diabetes and things. But I always love when Matt says, like, what's your saying about measuring the nails?
Once the metric becomes the goal, it ceases to be a good metric, right? If you're trying to just focus on one thing to make that score look good and not really understand like the spirit of, so that's what goes back to the why, right? Like, why are we measuring this, that, or the other? Yeah, so I always say, like, why are we measuring this metric, right? Why does this matter?
What problem are we solving? So helpful.
I'm actually curious. I never really thought about the idea of metric variation because for me, like that, I just anchored in my mind that that should be a shared goal across everybody. But I'm actually curious, Rick or Thomas, from your end, other organizations you've worked with, has there been like an example of a metric that's varied per site or per population or something that's like sliding scale? Because also from a ease of putting it on a Tableau dashboard, like kind of helps to just have that same dotted line that everyone's shooting for. But I'm curious, is there an example that you guys have seen at other places?
Well, I think what you alluded to earlier is aligning on, the metric, right, which is the formula, and then the target for that metric is something that we're seeing across the board that is very often not in place yet. So the status quo is that there is a variation in how people have this in their minds, like this is the target that we're shooting for, or even just writing down simply the formula. Because an example, I think my camera's acting up. One example that we see come back again and again is patient engagement, right? Patient engagement comes back everywhere in every care organization is crucial because it is indeed, Melody, to your point, right? It is a leading indicator, right? It is kind of a controllable input metric that is predictive of a better outcome if you get your patients engaged more, right? And so, but then ask people to write down the formula how they measure patient engagement. Within the same team, you'll have 5 different ways of writing down that formula. And so just defining the metric is already very difficult.
We have I did a benchmarking between multiple hospitals in terms of patient satisfaction. And then the variation that we saw there in outcomes was mostly focused on life expectancy, quality of life, and also just patient satisfaction in general. Although it was the same hospital, we had like differences between different locations. And we had a long discussion of like, why is that possible? And we were always like trying things out. But then to Thomas' point, these are all very lagging indicators. And so we were just like trying things out and then hoping that in a few months we would impact the metric. In most cases, you don't. And that's when after a few months, we just realized like it's pretty stupid to keep focusing on these lagging indicators. And that's when we started focusing on these leading indicators, which are all focused on to Melody's point, it's all focused on the process itself. Like, why is the process different between this hospital and this hospital? And then it was about the amount of follow-ups that we were doing, the amount of consultations that we had. And I think that's very much aligned with all things that you've also been saying. And maybe a follow-up question here is then obviously once you start creating variation in the processes, to your point, because every healthcare setting is unique, how do you then define the guardrails for where variation is permitted and safe versus where there is a hard requirement or expectation for adherence? Because I was talking to another care setting, they have about 500,000 patients, and they have a very strict policy that everything that is like a little bit of doubt, you already need to escalate to the clinical leaders. But this creates a lot of pressure on the clinical leaders because they had like so many messages on an everything or on a single day. And so how do you have you tackled that balance at Sutter? And is there like any learnings that you can share, maybe Matt, starting with you on that topic?
I'm trying to think. I'm thinking more kind of just like with my informatics hat on. We're on Epic as our EHR, and like the bane of my existence is workarounds. Everyone, I mean, I was that guy in residency and before. It's like, oh, this process doesn't fit my workflow, so I'm gonna create my own personal workaround to kind of because it'll make my life go faster today in this visit or in this moment. So for me, it's kind of I've sort of devised different ways to monitor for workarounds. I guess it's monitoring for deviation, and a lot of times it's exactly those things, putting in kind of these interim process metrics. What's a good specific example? Video visits, I guess, is one where it's like during the pandemic, you could kind of use whatever you wanted. You know, you could use FaceTime, you could use Google Meet. Pandemic restrictions were lifted for requirements for the technology used to talk with patients because pandemic. As we start to roll those back, it's kind of checking to see like, okay, are we using now like the video through Epic or the video through the HIPAA compliant Zoom, things like that. And then it's like, no, you find out that everyone's like not doing that. So it's putting things in place, being like, okay, just running reports basically kind of in the background to say like, are the stated process metrics being followed? This process being, are you using the right, what software are you using to connect with patients for these things? So for better or worse, I think better for me, worse probably for the front line. There are a lot of tools now where we can kind of monitor these electronically. We don't have to Melody's point, like sit there with a clipboard. A lot of these things are kind of automatically being collected, and then we can kind of just plug in periodically to say, like, okay, are they following this or not?
Yeah, this is a tough one, like guardrails. But just a couple of things, like it's not always that black and white. Like as an RN, like our role is to always understand patient stability at all times. And that's not always something that you can, it's not black and white. It's not like, so you have to kind of trust the clinical judgment. And there is definitely a way to review and peer review and look at quality and like what should have been the standard of care. But just one thing to add is I think it's so critical to have multidisciplinary efforts on this. So having your quality and safety folks and those who we have like a system to report, errors and near misses and things like that. Like that's critical that everyone is aligned with our culture of safety and that we really need good tools. But because there's been times where that we could have done something better, or a patient, it's just really important to listen to the patient too. And so our nurses are really good about asking, is there anything we could have done better? And then I want to be able to take that and have like a process for reviewing, how that call went and before it becomes an error. So it's really important.
So
Just
thanks.
one other.
Oh, go ahead.
one other quick point to make is, since we're on a tech podcast, we'll talk about AI.
Mhm.
This is what I tell our staff, particularly the nurses and the MAs, is like, I need you to be a human and think, right? It's like we have our flow charts and our guardrails and like what we recommend, but it's like you're also the human talking to the patients. Like your job's not in jeopardy from AI yet, because like I want you to use your brain and kind of use your clinical judgment at whatever's appropriate for your level. So anyway, that's a protection against AI replacement of our workforce.
Before we move on to the next section in the conversation, there's one more related question from the audience. And so what were some of the biggest hurdles, political, technical, clinical, bureaucratic, that any of you have encountered when trying to standardize a care flow in a large organization? What methods have you found effective? So one thing that we can say, because we've obviously seen a lot of customers having to tackle this exact problem, and might sound a bit strange, but we actually advise people to scrap the word standardization from their vocabulary and to go towards continuous improvement. Because if you have a team of people that need to standardize on something, all of a sudden egos become important and everybody needs to have their viewpoint represented in that standard that needs to be implemented. But when you go into a continuous improvement mindset, and whether it's called CareOps or lean or something different, all of a sudden people are okay with, let's just roll out a V1, and then the data will inform what the V2 should look like, or what experiments we should run to evolve towards a V2. And so just basically scrapping the word standardization from the vocabulary is actually the advice that we from CareOps and AWell would give. Any thoughts on that, both of you?
No, I'm just going to fully steal that. I like that. Because I think we do say, I mean, we talk about documenting standard work, but I think giving that idea, and I guess I verbally say this, it doesn't say this on the sheet, is that like, I kind of actively discourage our groups to like print out the standard work, because the expectation is that it's going to change. It's like, here is the link to the shared Word document that we will update as we make changes. But yeah, try not to print it out because it's going to change. Or if you make sure that you write the date that you printed this out so that you can always reference back. So, but I like this idea of just kind of saying that this is our continuous improvement document, but this is where we're at today. Yeah, totally stealing that. Thanks, Thomas.
The lens is
Mhm.
sorry, the lens there is really standardization is the best you know today, but it's the thing that needs to be improved tomorrow. That's how we try to sell it. That always works, to Thomas' point, because then the egos go away. But Melody, feel free to tap in with more knowledge on your end as well.
I've seen a ton of bureaucracy, political, technical, clinical, have been through the gamut. Yeah. So I don't have the answer, but a lot of lessons learned. And I just tend to come back to like, remember the patient. Like if you do what's right for the patient, you're doing the right thing. So the other thing is involving everyone. So there were like implementations that around like advanced care directives, a really cool technology that's cloud-based. It rolled out throughout the whole system, but forgot such a key person in the workflow at the front desk who like literally scans in the papers. So it's really important to be humble and learn from those opportunities. But yeah, but remember the patient and involve, don't overestimate folks that you may have forgotten to ask for their input on implementation.
And so when you do the implementation, what kind of training or change management needs to happen to ensure that your providers and staff are equipped to deliver the care under the new version of the care flow, or under an entirely new care flow that was designed with the stakeholders that you mentioned? Matt, how are you looking at that from like a clinician perspective? Because we all know how stubborn most clinicians are, so training is also extremely painful for those roles. So have you found like any good things besides free pizza that helps with that change management process?
Even that has kind of fallen off the free pizza side of things. I think a lot of it is like two things that I kind of think about whenever we put in a new process is that, like, one, it's always easiest to start with like the newer clinicians. So like we have this idea of starter packs. So when we hire somebody on, it's like basically this is your set of referrals, that like common referrals that you're going to use. Again, 80-20, right? This will hopefully get you 80% of your job they're set up within the first 24 hours that you're working in clinic. So this idea of starter packs where there's kind of like, here's like the baseline set of things, you know, there's some things that you're going to either tweak for your personal practice and or just kind of the region of the city that you're in. But having these starter packs has made things like so much easier. And it helps kind of that crosstalk where you're like, oh yeah, everyone starts at this, you know, new baseline, not completely blank. And that's just setting up their Epic side of things. The other one that we really focus on, at least here locally, is you can train the doctor so much, but like we don't listen, we don't watch the videos, we don't read the one pagers even. But training the staff that's around them, so it's kind of like these like this halo of support. So the MAs, if you can get the MA to like walk the doctor through whatever in the moment, oh yeah, this is the new way that you put in the referral, or like when an SDOH flags for here, this is the order number that you put in. If you embed that at the MA and staff level, and they are much better about kind of having daily huddles and putting these things in. That's how you kind of have like a bottom-up way of reinforcing teachings to the doctors, which, I mean, I'll be honest, no one reads their emails, no one reads the one-pagers, no one pays attention during meetings. So I go in with that assumption and then kind of work on the other ways around to reinforce that learning.
So in our previous CareOps webinar with Carbon Health, what came up was, you know, ideally a change in a process in a care flow comes with no cue cards, right? So it should just be live in the system that is being used by the people in their day-to-day at the point of care, whatever their role is. Now, Carbon Health has their own, you know, proprietary developed software that they can continuously tweak. With you guys, that's less so, right? So how do you deal with that with Epic? Is everybody like you, Matt, finding workarounds, or can you walk us through the process there?
To be fair, workarounds was my old ways. Now I'm the standardization. I'm the continuous improvement guy. I think the pieces that we look at, the importance of piloting, I think is there, because again, Epic has like their global way of doing it, literally global way of doing it, right? How they deploy across the world. And then, so that's like their foundation builds, what they call it. And then like, how do we tweak it for Sutter as a whole? And then how do we tweak it for what we're doing locally? So there's kind of these three layers of customization and kind of figuring out like, you know, what's going to work. So piloting, that's like the biggest help. So when we do have the opportunity to put in a new workflow that we can kind of just put, you know, set it up with a narrow group of people, that's where it's super helpful because we can kind of work out the kinks. The one other piece that I have learned over, so piloting, super helpful, but then two, your piloteers tend to be, you know, on the diffusion of innovation curve, like the innovators and the early adopters. So like our tolerance for like things not really working or like gets papered over because we get to play with the cool tech first. So like having, and so that's what I've trained myself to do and tried to train my team to do, is say like, hey, think about this from the view of someone that like has to get through 30 patients today, right? They don't have the same time that we do. How would they look at it? So it's building that empathy for kind of that early majority part of the diffusion of innovation curve. So while you're piloting, think about the early majority. And I think that's like a learning that I've had over the past few years that's different kind of than ways that I've thought about it before.
Does that local level allow you enough agility to adapt things? What can you walk me through the lead time for a change, for example? How does that work?
Fair question. I'm trying to think if I can go through any specifics on some of these, if there's a specific one that we've rolled out. In general, like, so like when we take an Epic upgrade, we're talking about doing one now, like that is usually kind of on the order of like a 3 to 6 month lead time. Like these are all the things that are going to happen, like keep an eye on things. And for the most part, our team is great. So like the Sutter global team is great. So they'll kind of iron out those things. The thing I'm looking at locally is like, what's going to break somebody's workflow and stop a clinic day dead in its tracks. So like, those are like the big red flags that I'm looking out for. And then those are the things that I'm kind of over communicating and saying like, hey, here's the change that you're going to have to do to accommodate this new workflow. Button's going to move from the left side to the right side. So those are the pieces that I think at a local level, I'm kind of thinking about, and then trusting that at the system level, they're aligning some of the things in the background. And Melody, I don't know if there's like, you know, nursing standard protocols or things like that that you have to navigate at the system level versus at the local regional level.
I've just had a lot of experience in design and delivery of training. I've been to Epic Mothership, and it's really interesting. Like when it comes to customization, Sutter actually did a lot of that. That's why we have disparate, design. So it's really interesting because everyone was allowed to just customize in their different area. So all I was going to say is just like just-in-time training tends to be, I agree with Matt, like nurses we don't remember anything from that enterprise training we get day one. So what we're experimenting with now is a partnership with enterprise training, and because they can never answer the clinical questions. Nurses are there trying to figure out, how am I going to take care of this patient with this tool, and they don't get those questions answered. So we're doing like a multidisciplinary training, and also doing just-in-time training. So, but ideally the tool, it'd just be so intuitive.
Oh, that's the one other thing that I'll throw in there is training to workflows and not to features. And I think that's a big change that we've made here probably over the last year or two. Because before it's like, this is the new feature. Like when you go to this tab, this is how to do it. And then we realized that like one, people don't really pay attention. But then two, it's like, okay, no, this is the new workflow when it goes from the MA rooming the patient, and this is how it flows into the doctor view. That's kind of, so yeah, training to workflows and like how this fits into the workflow really speaks to the why. Oftentimes it tells you, makes you more efficient, rather than saying like, make sure you click this button in this sequence, right? Because then you're just training a feature.
And so to really train on those workflows, you obviously need like strong synergy between clinical ops, also IT, to get to that adoption, but also get to that continuous improvement. So maybe Melody, for you, what are some of the working principles that you have adopted to really bring that synergy together at Sutter that you would recommend others to also adopt, if you maybe can pick one or two that you really, really like?
Between clinical and IT.
Yeah, clinical ops and IT, or anything in between that you might like doing et cetera.
That's an interesting question. I've tried various different approaches. I think it's an ongoing challenge because I just think we all speak a different language, whether it's, I don't want to steal your thunder, Matt, but SBAR, like I'll let you talk about that. That's a communication tool. But I've used user stories and patient journeys, thinking like, oh, surely IT will resonate with this, and maybe not so much. So it's between like I think what's missing is the design. Like from my experience in startups, and other companies where you have a designer, like the IT folks, we're the customers, they want us to tell them what we need. There's a gap there. So if you have people that can translate that is gold. Hold on to them, because they tend to be misunderstood. Like engineering is like, you're not an engineer, and then they're not a clinician. So anyway, that's really key. I do know a couple of folks, and informaticists tend to be that way, where they're like a hybrid professional. So I think you really need that translator who understands how the features work, and then what the workflow is, and can really get into those details. So start there.
I think that what I've realized, and similar to Melody, I've kind of bounced around. I've been at like large academic medical centers, worked at some startups, back at like a large health system now, is what's missing both in the academic medical centers and in the large health systems is you don't see a product role. So there's a lot of project managers in the large health system, but very few product people. And there's people that I think informally play that role, to Melody's point about hybrid professionals, and you have people that can kind of speak both of these languages, but it's generally not a stated role, in terms of a title. And then not one that's really like looked for, but then you realize how important it is when you have someone with a product mindset on your team. And again, that's you're always thinking back and forth, because again, engineers and analysts like to check off tasks. And then clinicians need to just do the workflow kind of in flow. So I think like someone that can basically take that workflow, turn it into tasks, and then assign those tasks to analysts that's product, but they don't have that specified role here. And then the other piece I'll speak to is the idea of an SBAR. I've really liked using it. I think I first saw it at UCSF when I was there, and have taken that, and we use it also at Sutter. Stands for situation, background, assessment, and recommendation. Usually it's used on the clinical side fully. So like the nurse will let the generally telling the doctor, like alerting them to like, hey, here's the situation. This is the patient is decompensating. Background, here's like a short sentence of why they're in the hospital and things that led up to this. What's my assessment and what's my recommendation? So that's just like a really standardized and quick way of describing what the issue is. we've used that for communication between clinicians to analysts and analysts back to clinicians. And then that way everyone's kind of using this shared language and it kind of keeps it clinical. So like, why is this important, right? And a lot of times we use that often when there's feature requests coming from the clinical side to the analysts. But analysts will also kind of use that as a way of saying like, oh, this is a problem. And this is why it's going to be a problem for you. So yeah, the SBAR format, yeah, we've been teaching that. And I think having that, again, gets everybody at least with a shared language.
So to your point about the roles, Matt, we see several of our customers actually defining a CareOps role. And the CareOps role very often has as the product lens as a basis. To your point, product is incredibly important. And this CareOps role brings the clinical lens, the engineering and the product lens together very often also, with quality and compliance in the back of their minds. But that's kind of like the spider in the web to take a different lens than either indeed the project managers or the engineers. And we see that a lot in the more, the newer tech-enabled services companies, like, the virtual digital health companies. But we're starting to see that as well in the more traditional health systems as well. So I think that trend will continue, because you make a really good point. The product mindset is a very different one than the project one.
I actually had a meeting with a large health system 2 weeks ago, and I was talking to the health system's head of engineering. Normally, I always talk to head of IT or something, and also a product guy. So I think it's definitely changing, but it's changing slowly. But we will get there in 5 years or shorter. And then maybe a last question on my end. Maybe Thomas has one more. Obviously, we talked a lot about continuous improvement as the core principle behind CareOps and all of the frameworks that we talked about. But as a provider, it can be very challenging to prioritize and implement process changes in a healthcare environment, because there's like so much happening and you don't want to change every single day. So how do you think about like balancing the need for rapid improvements while also taking the importance of maintaining stability and minimizing disruption in patient care? Do you have like cycles, like we review our processes every 6 weeks or every 8 months or whatever? Or do you have like any frameworks in mind that you think are worth sharing, Matt? Maybe starting with you, and then Melody, you can tap in afterwards.
Yeah. No, doing doing this talk with you guys is helpful, because I think it's helped shape kind of maybe again ways to be more disciplined. So short answer is like we don't have strict timelines that we do it on. My overall frameworks that I use is actually just it's maintaining both patient trust and clinical team trust. So I think that's the thing, is we go as fast as people can trust us to like not screw things up. Because it's one of those things where you go live or you implement something subpar that takes years to kind of recover from that reputational hit. So I think that's one of those where it's like push. So building trust, I think, is important too. There's just that relational piece and kind of saying like, hey, we're gonna take a flyer on this, but like trust me. And then making sure that you have a safety net. So again, patient safety always first, but I think that trust, both again from the patient side and the clinical team side, are important to keep in. And you can do that. Again, it's never as fast as I want it to go, but I've also learned to like recalibrate my speed goals as well.
Yeah, that's awesome. We're learning a lot about the way it's so important to understand how your team thinks and who's the one who executes and gets things done and who's the one that likes to be the ideas person and explore. So we're using this framework right now called 5 Dynamics around change, because I think it's really important when it comes to getting a team together to make a change. And then right now for Pop Health, we're working on like my sole goal is to get each clinic to have one strategic improvement, because the scorecard has 37 things. It's overwhelming. So it's like, what is one thing we're going to work on this quarter? And then just using literally an aim statement PDSA sheet. Like, so we'll see how that goes. Depending on the provider, they might want to do 5 things instead of 1. Not be surprised, but I think it's really important to be strategic and understand the problem we're trying to solve. So even that is a huge accomplishment if we're learning that language and practicing that as a division.
So we're almost out of time. Last question, and this can be really short, like quick fire answer. So after decades of patient centricity, and I hear you talking about putting the patient front and center and patient safety, all good and well, but we're seeing that the care team experience is becoming more and more important. Clinicians can go to many more places to work, and we're burning them out at a rapid clip. And so what would be your one advice to the audience to safeguard care team experience? So give me a short answer. First thing that comes to mind.
I mean, I'll just speak, I guess, for me personally, it's the teamwork piece, right? It's like wanting to be a part of that team. And again, so that's staff, that's clinic, that's admin, that's ops. I think having everyone aligned there is kind of what keeps people around. Is the main thing. Because then how do you spread work? How do you not feel like you're dumping work on people? So the teamwork, I guess, would be my one-word answer.
Yeah, I couldn't agree more. It's really important that you have a space where people feel psychological safety, that they can speak up and that they can trust each other to do their best work and also bring their best ideas to work. So I think that's huge.
So teamwork makes the dream work. we use that almost on a daily basis with our kids. We have 4 of them, so it's an absolute team.
Yeah, one of our physicians literally read research on this, and he said it's not rocket science. At the end of the day, you have to be with someone you're willing to grab a beer with or tea, like whatever. So that's how you know.
The what is our test again, Thomas? The
airport test.
Airport test, yeah. Maybe you can explain to the audience as last bit of advice.
Yeah, so in our hiring processes, we ask ourselves the question. It's one of the questions in our where we take notes on the candidate. Is would you, if during a snowstorm and you're stuck at an airport for 3 hours waiting for your flight, would you be willing to spend those 3 hours with this person that you're interviewing? So that's a specific question related to your taking a beer or tea, Melody.
I like that a lot.
I see time's up. Before I give you the last word, maybe a quick update on CareOps. So we will have a panel in July. I have not created a sign-up page yet, but it will probably be with the founding team of Iora Health. So one of my favorite Harvard Business Review cases written about one of my favorite companies. So I'm really excited about this one, or the one coming. I will give you a link soon. Maybe Matt and Melody, where can the audience find you when they have more questions, or where should they connect with you to keep up to date with all the smart things that you say on social media and other places?
I don't know if they're smart, but I say a lot of things. LinkedIn has kind of been the place that I've gone to the most. So if you just look up Matt Sakumoto, that's where you can find me.
Matt is one of the most active LinkedIn physicians I've ever seen. It's really impressive. But yeah, you can find me there too. Melody Sybach.
All right. Make sure to connect, and thank you for your time, and looking forward to the next conversation.
So much.
Bye-bye.
Fine, thanks.